So I got
Oh,
some
gee,
treats.
it's gluten-free. You are.
And then this happened in the
you.
parking lot.
Yeah, my burps too.
So, and then I almost got pulled over.
You had a busy morning.
So I exited and I went to Dunkin' Donuts drive-thru and he couldn't find me.
Oh, that's why you didn't get pulled over.
Yeah.
I just thought you got lucky.
Why did you get pulled over?
Because there's so much school traffic near my area that I was like, oh my god, this is insane. And it was taking forever for me to even get like down the road. So then I was speeding. And then he was facing the other way, so he had to like turn around. But then I was like, oh, let me exit real quick.
You weren't speeding through a school zone, were you?
No, this is on the highway. But I'm also getting my treatment, so I have to wear this because
I was going to ask you that. Okay, that's
I'm
fine.
immune compromised.
So
Like,
you're okay to be here? Just
Yeah.
that you have to wear the mask. Okay, that's fine.
it's like what is it called? Immunotherapy.
Yeah.
And it like lowers my immune system really, really low, so that I.
Right, that's
But
right.
like before COVID happened and I was getting treatment, he was asking me to wear a mask. I just didn't.
Yeah,
But now that COVID happened,
you definitely have to wear a mask.
yeah.
Would you be better with an I-95 mask? Would you feel better?
I don't know. I don't care.
You want an I-95 mask? I've got some in my office.
Sure, if you have one. I
Do we need to wear a mask?
No, it's okay. It was okay. Yeah, and then Trey was this weekend. He was like, I have a sniffly nose.
Oh no.
So he got tested. It was negative, but I was like, you need to wear a fucking mask.
I just want you to know that I already started recording because I just wanted to record your story. Thank
You're
you.
an asshole. Hey guys.
YouTube is gonna flag this now since we cussed.
Thank you.
Oh, they're so sweet.
Okay. Okay. Let's go through the lines.
Oh, bless you.
Oh, that's
I figured.
Okay,
Mallory, stop.
I'm not gonna pass on those.
Thank you. I hate you. Oh, you don't get any.
Okay, that's fine.
Oh, that's right.
Thanks. Love you too.
I want cheese on it. Oh god, that'd be amazing. Over ketchup.
There you go.
Yes.
Yeah, there's like 4 more things in there. Thank you.
There you go, courtesy of Chile Medical Center. My husband brought them for me and said, here. So, oh good lord.
Yeah,
What are
that's for you.
these?
They're good. Very good.
Yeah, they are good for some reason. Who would have thought that?
Okay, Barry.
I know.
Okay.
How
So,
do I wear this?
Her fingers are so greasy.
Like that.
as I was saying before,
Is this how I wear it?
you should wear one of them up here.
Okay.
So put that one up there and that one up there. Actually, you should have, no, that one's fine.
Okay.
This one is good as long as it's comfortable. You might want to just pinch your nose a little bit. Yeah, that's better. And if it slips, you might want to put it on top here,
Mhm.
but it looks good actually that way.
Okay.
Did you continue? I think so.
So as I was saying before, Asia interrupted us coming in. Do you have any paperwork that you need to give me, Asia?
Yes. But I don't want to give it to you.
Okay, so as I was saying to everybody, you need to have all of your paperwork, all of your paperwork here by next Monday. Otherwise, especially the evaluations. Otherwise, I can't give you a grade for clinical. So I think you may have, no. What's that?
I don't think this was graded fairly.
That's, we're missing, oh no, we're not. Okay, forget it. That's fine. So that's the one that I need especially, okay?
So according
Okay, so let's do a review. So this is what we're gonna do for this one is it's out of 40. There's 40 questions. 30 of which are multiple choice. 10 of which are short answers. Close your mouth, you catch a fly. Yeah.
Oh, shit.
It really is short answers, like definitions of something or other, so. But we'll go over it. That's what my mother used to say when I opened my mouth. Close your mouth, you catch flies. Okay, so, somebody tell me what IMRT is. What is IMRT?
Intensity modulated radiation therapy.
Intensity, all I heard was intensity modulated.
Radiation therapy.
Right. So, what does that mean? What does intensity modulated radiation therapy mean?
That their arc uses leaves.
Say again?
That the arc uses leaves.
Doesn't necessarily have
It
to be
doesn't
arc.
IMRT,
Oh,
as I
well.
keep telling you, is not always
Arc.
rotation. It's not always an arc. Why is IMRT different from 3D conventional?
It uses the MLCs.
Say again?
It uses MLCs.
MLC is used for everything, whether it's a parallel opposed pair or a single field spine or whatever. So MLC is used in case instead of blocks. So just because we use MLC doesn't mean to say it's IMRT.
There's different MUs used for different spots of the body and different sizes.
Okay. A little more in depth on that one.
I don't know, it's just what I have wrote down. Next to IMRT. I have IGRT, obviously. You image before you treat.
No, we don't necessarily use IGRT for IMRT. We normally do, but we don't necessarily have to.
Oh, I think at Flagler we do it for everything except for electrons.
And adjust the amount of dose going to what your area you're treating to adjust the intensity of it as it's moving or not moving,
By which method?
and moving the leaves. As it's
So it is IMRT is actually done by varying the intensity across the field by the use of moving the IMRT leaves. Has anybody heard the phrase rapid arc? What is rapid arc? Those of you who've heard about it. What is rapid arc? It's used mainly by certain manufacturers.
Is it the FFF?
Say again?
Is it the FFF?
I don't know what you mean by that.
I don't know either. Never
Finding
mind.
free filter.
That
Flatly
one.
filter free?
Uh huh.
Oh, no.
Nobody knows what that stands for.
Hmm?
Nobody knows what that stands for.
is rapid
For real?
arc when the beam stays
Huh?
on
Your clinic?
constantly
Yeah.
as it's rotating and treating.
That was like one of the first
every-
questions I was asked.
The entire
What's
rotation
FFF?
that it's going around.
Can I
Okay.
say it again though? No, I'm scared. What is that?
Rapid
Finding
arc
free filter.
is exactly the same as VMAT.
And then filters go in it straight.
Rapid arc is a trademark of Varian Medical Systems. So if you're using a Varian machine, you're using what they call RapidArc. That is the trade name.
Does Electa have
Or
a version
Varian.
of that?
Electa and any of the other one, the generic name for it is VMAT.
There you go. That's what I've heard of. I might have lied. I don't think I've ever heard of Rapidar.
So it's like, if you think about
Oh, God,
vacuum
sorry.
cleaners, vacuum cleaner is the generic phrase. Electrolux or Hoover or something are the trade names of the various companies that make vacuum cleaners, right? So VMAT is the generic name. And just because I said that, what does VMAT mean? What does VMAT mean? What is it, what is VMAT short for?
Volume or volumetric modulated arc therapy.
It's the same as RapidArc, exactly the same. Most people, if you say RapidArc, they'll know what you mean, but the official name for it is VMAT. Why do we use MLC? What is MLC and why do we use them? And why is it used?
To shape the beam.
To shape the beam, okay. What else does it do? Shape the beam as in shielding, right? What else does it do? We've already mentioned it. What does it do in IMRT?
Adjust the intensity.
Adjust the intensity, yep. What else could it do? In most departments, we don't use wedges, physical wedges, but we use electronic wedges. Dynamic wedges are what they're called. Anybody ever see them used? Dynamic wedges? MLC is how you make the dynamic wedges. So the dynamic wedges is if you have a dynamic wedge, if you're doing, say, a non-IMRT breast, and you need to put a wedge in because of the slope, and you don't want to put a physical wedge in, partly because you don't like to use them, partly because you don't have them, then you need to use a wedge somehow. So what you do is you use the MLC. So what happens is the MLC starts from open, and it slowly closes. And the amount of closure that it does, or how slow or fast it closes, gives you a wedge into the beam. So it compensates for the slope. Does that make sense? Okay. So what is respiratory gating or respiratory gating?
Isn't that when we use the belt to, like, make sure that they don't take a really deep breath? Is that what I'm thinking of?
Yeah,
Oh wait, no, sorry. It's a breath hold patient.
somewhat.
So, yeah.
With a machine.
breath in or breath out, and it
Stop and
shoots.
start.
Yeah.
Yeah, so it's basically, overall, it's breath control.
Yeah.
Right? That's basically what you're doing. It's not a case of you have to hold your breath, or your breath has to be small. It's basically breath control. And there's various ways of doing it, but it's all included in respiratory gating or respiratory gating.
So I have a question. Probably for anybody that has done that. The machine stops itself when they take it a deep
Yeah,
breath?
in some respiratory gatings that are computerized, so that you have a certain level of
To protect the heart, right?
yeah.
That way-
Okay, so there's your breaths. Okay,
There's some big.
and inside these two lines
Breath.
is the area that you want for a patient's breath to be good. So what happens is that there's a software that controls this, and if, when the patient's breath is in a cycle, so the patient breathes and breathes and breathes. So when the patient's breath is outside of this line, the machine doesn't work or stops. Here, the machine gives treatment. Here, the machine doesn't give treatment. The machine may continue, but the radiation doesn't come out. So as soon as it gets in between these two lines, the treatment continues. If it's outside, the treatment is not given.
Is this the 4D CRT?
Pardon?
Is this the same as the 4D CRT?
No, it's purely breath control. It's completely different.
I think we do it different at Flagler because we literally tell them, all right, take in a deep breath and hold it,
Yeah,
and then they do that, and then we start the treatment, and then when they start breathing, we
yeah.
pause it.
So this is a more advanced way of doing this.
Okay.
So if you can get a patient to hold their breath for 30 seconds, for example, you can treat a little bit, stop, let them breathe a little bit, breath hold, continue. So this is actually allowing the patient to breathe relatively normally, but they usually have a band across their chest anyway, just to sort of help them not breathe too heavily.
Yeah.
You must remember that, of course, some of these patients are not breathing normally to begin with. So on that vein, what kind of treatment would we use respiratory gating or breath hold or whatever it is to treat?
Left breath
Left breast? Okay,
because the heart.
pardon?
Because of the heart.
The heart, what else?
Lung, maybe?
Yeah. What else? What else moves with the diaphragm?
Where's the colon?
Pardon? What else moves with the diaphragm? If the diaphragm's moving, you're breathing.
Doesn't the liver move?
The liver, yeah, part of the liver, usually the upper pole of the liver. What else? What else is around there?
Your stomach. I got that.
Pancreas. So all of those, you might use respiratory gating. So, if you remember, we discussed Gamma knife and cyber knife. What's the difference between a Gamma knife and a cyber knife? So apart from that difference, one using cobalt 60, and also you must remember if you're saying cobalt, you have to specify what cobalt it is, because there's a cobalt 59, there's a cobalt 60. So if you're saying cobalt, that is wrong. Cobalt 60. Okay, so apart from that difference, is there any other difference between what Gamma Knife does and what CyberKnife does?
So Gamma Knife is strictly for SRX, right?
Yes. Which one?
SRX.
No.
No?
Which machine?
Gamma Knife.
Gamma Knife. That is correct. What does CyberKnife treat? Just got it written down. What does CyberKnife treat? Can it treat brain? Yes.
Yeah.
It can basically treat any area of the body. That's one of the differences between Gamma Knife and CyberKnife. Gamma Knife only treats brain, only treats SRS. Whoops. What type of treatment would we specify something called Bragg peak? Protons. What is Bragg peak? What is it?
I think so.
Isn't it like,
Hmm?
it's like a D max for protons and then it just falls off?
Okay. Okay. I'll accept that. Okay. So, hyperthermia. What was hyperthermia? Or what is hyperthermia? As far as radiation therapy goes. Well, first of all, tell me what hyperthermia is.
Extreme. Living in New York. That's what it is.
Too much heat.
Too much heat.
Oh, hypothermia?
Hypothermia. Hyperthermia.
Hyper.
Oh, I thought you said hypothermia.
New York can get very hot too.
Yeah, that's true.
Hyperthermia is too much heat to the body. Heat stroke, heat stress, that type of stuff. Only taken to extreme. So what is hyperthermia in relation to radiation?
It's used to heat up the area of interest that you're treating in attempts to make it more radiosensitive.
Okay. So is this a new technique or not? Okay. When did we use hyperthermia before?
Risking dates now, really?
No, just general. Just general. I didn't mention it in class.
I don't remember. I know it's not used very often because they looked at me like I was from the plant when I asked them if they did it at UF.
No, they don't.
All I have is ultrasound.
They're like, no.
What the
No.
hell is she teaching these guys? Yeah. Hyperthermia,
When I looked up
was
for my
used in the
son,
early
I saw her talking
1980s.
about hyperthermia. I said, what the fuck
that's
is he
probably why
teaching us?
nobody's heard of it.
Well, I think two of them, the more seasoned therapists, but they just kind of looked at me out of the corner of their eye and they're like,
No, I don't think anybody does it here, actually, to be honest, so, okay. So, why do we use hypothermia again in radiation, I'm sorry? Say it again?
An attempt to make the cells that we are trying to treat more radiosensitive.
Okay, so since Asia mentioned hypothermia, what is that? And I hasten to add, it's not used in radiation therapy. What is hypothermia? What is it? Too cold, or the body gets too cold. There are some people who have survived, usually children, who have survived in very, very cold water for 2 to 3 hours and have been resuscitated. There is an old paramedic saying that you're not dead till you're warm and dead. So they've pulled out people out of frozen lakes and very, very cold lakes and resuscitated them and they've been fine. But usually it applies to children, small children. But it is possible. So that's why they say that you're not dead till you're warm and dead. There's a possibility. Anyway, that's a little bit outside of your scope, isn't it? But that's okay. So there was something in hyperthermia in the PowerPoints that I sent you. Hopefully somebody read them. Called the thermal enhancement ratio. Would that be used for treatment with hyperthermia, hyperbaric oxygen, or something else?
Something else.
Hmm?
I don't know.
It's used for when we're treating hyperthermia in radiation.
Can you say it again?
Thermal enhancement ratio, or TER.
Is used with hyper.
Hmm?
Is used with hyper.
Hyperthermia.
Thermia.
Yeah, okay. Okay, so I'm gonna give you an abbreviation. You tell me what it means. Or tell me what it is. IMPT.
Intensive modulated proton therapy.
Somebody can read the books.
Wow, that was very smart of you.
we went over it like 2 weeks ago, I think.
Yeah, we did. Yeah. So
I wouldn't know.
IMPT is inversely or intensity modulated proton therapy. So it's basically IMRT with protons. So let's get back to respiratory motion. Patient respiratory motion. So you, Asia, you were saying that the patient is asked to hold the breath
Mm-hmm.
for
So
X number of seconds or as long as they can.
yeah, so what we do is for like their sim, we do like as long as they can, and we have a counter to count as how
Mhm.
long they can hold their breath for each time, and then that's how long we deliver treatment for, and then we stop it like
Right.
2 seconds early and tell them to breathe, give them a second, and then we wait till they're like breathing normally and not taking deep breaths after that.
Mhm.
And then we tell them to do it again, taking a deep breath and hold it. And we
Okay.
do the seconds, and then, so some patients have like 10 stops,
Yeah,
depending on how long they can hold their breath
it's
for.
sort of something like, what, about
Like 30 seconds.
30 seconds. So you wouldn't, for example, ask your patient to hold their breath for a minute.
Unless they can.
You probably couldn't,
No.
because even a healthy patient may have difficulty holding their breath for a minute.
Mhm.
Just think about you, how long you can hold your breath for.
I think literally the max I've seen is like 38 seconds.
Mm-hmm. The other thing to imagine is that, let's get finished with this now, I'll tell you the story. So what else could be used to help the patient breathe a little more shallowly?
The belt.
The belt, a compression belt maybe? Yeah, okay. It's called an abdominal compression. Or just ask the patient to breathe as shallow as possible. A lot of patients won't be able to do that because they don't know what shallow breathing is, so the compression helps somewhat. And that's why in some departments they use this technique, because you can't really, especially if it's more than about 2 minutes, your patient will gradually get deeper and deeper and deeper as far as breaths go.
I've seen a switch on the wall labeled respiratory gating, but I've
Yeah,
never seen him use it. So,
no,
but it's labeled. Everything in there is labeled. Like everything has a sticker on it. It's great. Like there's probably literally a sticker that says like emergency stop button, like everywhere. But I've never seen him switch it.
so the big red button doesn't give you an idea, they have to put a
But I'm
label on it.
serious. Like they're like weird about labels. Like everything
Well, that's fine.
has a label. Like
Yeah.
water bottles. Like I mean, it's just like everything.
So,
Somebody just like the label maker.
They really do. They joke about it all the time.
so, protons, back to protons again. What is the main difference between protons and photons? What's the main difference? Are they, for example, more or less expensive to produce?
Protons are more expensive.
Okay. So what is the main, why does everybody say, well, it has to be protons? Why? What's the difference between photons and protons?
The fall off, the difference in fall off.
It's more targeted.
It's more targeted. Fall off, more targeted. Put them both together.
I can think about the image of it.
The sparing of healthy tissue
Yeah.
behind it, there's no.
Okay. So what you're telling me is that they only go so far and stop.
Right.
Right. Peak. Yeah. So they have a limited range. It can be enlarged, but they have a limited range. Is that what you're telling me?
That's what you're telling me that I'm telling you.
Is that what you're telling me?
Yeah.
If that's right, that's what we're talking
Yeah.
about.
That's exactly what I said.
So you have some more hints that you might need to drop if you want something more specific.
protons are direct.
Okay,
If you were us, what would
I was
you
gonna
say?
say, different than that here.
yeah, okay. No, you're doing fine. So if I was going to do a stereotactic radiosurgery, what would I need? Or what would I do?
Could you rephrase the question?
Okay,
As a patient, as a therapist, as,
we're always going for therapists here. You're not doing anything from the patient's point of view. This is you telling me what you know about whatever it is I'm asking you, not patient point of view. Okay, so does, for example, a stereotactic treatment need a dedicated machine? Why not? What can you do? What machine can you use to do stereotactic on?
do it on Linux.
So there are dedicated machines, for example, Gamma Knife.
I was just gonna ask, is the CyberKnife considered a linear accelerator?
It is considered a linear accelerator, a modified linear accelerator, yes. So, but you don't really need a dedicated machine. You can use a linear accelerator with some more bells and whistles. Most of the newer models of the linear accelerator can easily do stereotactic, either SRS or body. Does it have to be the brain? All I'm saying is stereotactic. I'm not saying SRS or body. So it doesn't have to be the brain, does it? What kind of dose fractionation do we use for, say, stereotactic brain? Dose fractionation.
3 to 5.
Stereotactic radiosurgery to the brain.
One fraction was.
One fraction. What about, I said dose also,
Large dose.
large dose. Small field size. One fraction. What about stereotactic body radiation therapy?
5.
1 to 5.
We have some 1 to 10s. What is that? They don't call it SBRT, do they? I don't remember.
No,
That's just
No,
a
that's
short
just like
fractionation
patients.
schedule.
yeah, it's usually palliative attachment if you do 1 to 10.
We do a lot of whole brains 1 to 10.
Yeah.
10. We do a lot of brains
Yeah.
at 10.
What's the minimum dose required for it to be considered SRS?
1 fraction.
Well, I mean, like the amount, like centigrade or.
That depends entirely on what they're treating. Some stereotactics they'll do as much as 2,000 in 1 fraction.
4,000?
In 1 fraction,
Yeah, maybe one of them is very
I'm not surprised. I would be too if I was given that one. Okay, so stereotactic body radiotherapy is small field, large dose given over 1 through 5, usually 3 through 5 fractions. Stereotactic radiosurgery It's one fraction, large dose, very small area.
Okay, that's what I was thinking of. If I had SRS, SRT.
Yeah. So you also need what they call reference, the frame of reference. What would that be? So what do you normally do with your patients before you treat them? How are they planned? What is used to plan the treatment?
CT scan and send.
What else might you use for a stereotactic treatment? Whether it's body or brain? Apart from the CT that you did planning. Excuse me.
CT.
No, this is before for planning. What would you normally have? Who's seen an SRS or an SBRT? Is there any modality that is used apart from CT? Any other imaging modality?
MRI.
Sorry?
MRI.
MRI, especially
Let's do a
for
bunch of SBRT.
SRS. They'll do an MRI and they will, what they call, fuse them. What does that mean?
Put the two images together.
See again?
They'll put the images together.
Yeah, you basically superimpose the images so that you can treat, you can see the different, so you have the best of both worlds basically. You have the MRI image and the CT image and you fuse them. So you can get the anatomy of both modalities. And it gives you a better idea of where you're going to be treated. Okay. Oh, lost tape. Okay. I'm just trying to see how I can freeze this without giving you the answer. Okay, so photon radiation therapy. What you have, say, 2 machines plus the dosimetry. How does the dosimetrist get the information onto the machines? Does he or she come over and say, I need to work on your machine and install all the stuff? How did he or she get the information from the dosimetry onto your treatment machine?
Don't they like choose it in the Eclipse plan?
Yeah, so you're using they're using Eclipse in the treatment area, or in the planning department, right? What are you using in the treatment area?
Aria.
Hmm?
Like Aria or
ARIA, okay. So how,
I don't like, it needs a crossover into the system.
okay, so what is that called? if the dosimetrist who's working on Eclipse pushes the information that the therapists need onto the ARIA system.
Integration?
A little more simple than that.
Technology.
It's a network.
Oh.
Duh. Okay, so the dosimetrist has his stuff in Eclipse. Eclipse is part of the LAN. Local, everyone know what a LAN is? Local area network. Okay, so the dosimetrist is sitting in his or her office, doing the plan, it's approved, everything's good, then they just push it using the LAN across into the treatment machine network, which is, in this case, ARIA. So what other capabilities does the LINAC have? Both LINACs, any LINAC, any new LINAC have, apart from the treatment part of it? How do you do portal images?
You have the MV and the KV.
Okay. How do you do CBCT? What hardware is on the machine to allow you to do things like KV images or cone beam CT or portal images? What hardware is on the machine to allow you to do that?
Panels,
Pardon?
panels, like the imaging plates.
The imaging, panels. What actually gives you,
Low dose X-ray source and the image receptor.
yeah, so you have a KV and an MV imager, right? Or a KV head, MV head, both have imagers. So the MV imager gives you the portal images that we take how many times a week? Or how many treatments?
Every 5 fractions.
5 every 5 fractions, right? And the KV imager is there to do what?
Cone beam CT.
Cone beam CT, yeah? Is that the only thing that the KV image is used for?
No. Can't you do a KV?
KV, yeah. Onboard imager. Yeah, OBI. Has anybody heard of OBI before? That's an onboard imager. You have a CBCT and an OBI. The OBI is usually KV. The cone beam CT is the CT imager. They both come from the same area, it's just different software. Okay. Can the machine, any of the machines, do non-isocentric treatments? Can the machines do non-isocentric treatments? So one more answer, yes or no?
What was the question? I'm sorry, I was
Can-
trying to
that's
type what
okay.
you said before.
Can the treatment machines do or treat non-isocentric treatments?
Yeah.
Okay,
Let's say yes to.
why?
Well, yeah, because you can treat a TBI.
Any of your Linacs would be able to treat non-isocentric. As we said, you couldn't do a TBI otherwise. Or electrons for that matter. Electrons are non-isocentric. Anything on the skin is non-isocentric. TBIs are non-isocentric. Anything you do extended SSD is non-isocentric. So, particle beams, which include, of course, protons, are they treated with a rotational gantry? Are they always treated with a rotational gantry? We know what I mean by a rotational gantry. Gantry that will move around them.
I would say no, not always.
There are some proton machines that are not rotational, they are static, and they only come in from one side. So you have to sort of move the patient around. So yeah, you're correct. The answer is that it is false. So, intraoperative radiation therapy. And have you tell me what that means? Intraoperative.
During surgery.
Yep, okay. So what kind of treatment, what kind of area, body part, shall we say, could be treated with intraoperative? Or most likely to be treated with intraoperative?
I'm just gonna throw out breast.
Breast is
I was
one.
gonna throw out breast too.
She got to it first. Breast is one. Yeah. Anything else? Abdomen is another. Sarcoma is another. Sometimes they will treat lung, but not very often. Okay, so what is accelerated partial breast treatment? Some people may have seen it done, some people may not. Accelerated partial breast.
Would that be like a sad?
Mm-hmm. That would be like a SAVI.
Okay.
Or the other one is called a mammocyte. It's same version of, different version, same thing. So Does everybody know what we're talking about now? Now that we've mentioned the names.
Brachytherapy?
It is counted brachytherapy. High dose brachytherapy. It is, it is done, as its name suggests, breast. A lumpectomy is done, and a catheter is placed in the opacity, usually by the surgeon as he's doing the lumpectomy. The catheter has a bulb on it that can be expanded, and radiation seeds are placed into the breast cavity by use of HDR. That's what Mammocyte or SAVI is. That is what they call accelerated partial breast treatment. How many fractions do we give to these ladies? Usually not.
10.
Or 10, but it's twice a day, correct? Okay, never mind.
10 fractions, 5 days, BID. You have to be careful about that. Normally they start Monday, go through to Friday. And at the end of the Friday, the catheter is taken out and a Band-Aid or a Band-Aid is put on top and we're free to go. And usually the CT, the first CT planning is done on the Friday before so they can get started immediately on Monday. And it is how many hours apart for a BID patient?
6.
6. They may say 5 in clinic, but
Oh no, they say 4.
but it is officially 6.
That's all I care about. I
For
just
the
want
exam,
officially.
it is 6, okay? Okay, so tell me what IGRT is. And? What is it?
It's using imagery to locate the area you're treating for consistency.
And? When is it done?
Some of it's in advance, some of it's during, before each treatment, before each fraction.
What do you mean some of it's done in advance?
Like the fourth, every 5.
Okay, but they're done as you're treating the patient, right?
CBCT, well, for ours, I'm sure it's different everywhere else, we use the CBCT every time, and then the fourths every 5.
Okay, so the part that you have to remember about IGRT is done immediately before treatment on the machine that you're going to be treating them on.
So then just
So you don't
CBCT.
move them. So if you're doing, you can use MV imaging, but it has to be done immediately before you treat them. Okay, that's the one thing about IGRT. Some people would say, well, that means they can do it in CT. So you do it in CT and then bring the patient over for treatment. That's wrong. You have to do it immediately before the treatment. So what kind of imaging devices can you use to do IGRT? I've already said cone beam CT. What else?
pretty sure we've said ultrasound, but I've never seen it.
Yeah, ultrasound can be done, yeah. Portal images can be done as well. Has anybody seen or heard of ExactTrack? Yes? No? ExactTrack is a computerized positioning device where there's two pieces of equipment on the ceiling, and they are brought down to the patient, and depending on how they move, they can check if everything is okay. Same as codebeam CT, only a different way of doing it. So if you ever hear the
Vision
phrase ExactTrack, that's what that is.
We have it, it's called Vision RT.
Same type of thing, yeah.
Two cameras.
Yeah, so it's basically the same, only a different manufacturer. Yeah. Okay. Okay. MLC leaves, how big are they?
Oh, wait.
5 millimeters width? Okay. Anybody get any other suggestions? They do vary, by the way, so there are several thicknesses. So 5 millimeters is one thickness. In some of the machines, you have two thicknesses. The lower and upper portions of the MLC can be a centimeter, and the middle section is 5 millimeters. So you may have some machines that are a centimeter wide for the MLC. And if you have a machine that does a lot of stereotactic radiosurgeries, they may have an additional group of MLCs that you can actually fit onto the machine that has 2.5 millimeters. So you can have a centimeter, 5 millimeters, and 2.5 millimeters. Has anybody ever heard of tomotherapy?
Yes.
What is it?
Mammogram.
Pardon?
Mammogram.
Mammogram?
Yeah. What?
Tomotherapy?
Yes. No.
No. You think they're the wrong one.
No.
They're the wrong thing.
It's not the same. Okay.
Tomotherapy is a type of treatment technique. A tomotherapy machine
That makes sense.
is a combination, if you can imagine a combination of a CT and a LINAC. It looks like a CT. It has a donut in the middle. And it can rotate around and shrink at the same time. So it's a combination of a small linear accelerator within a CT.
It's not the MRI one.
That's a different, it's similar, but it's CT, not MRI.
Okay.
So is it still considered IGRT?
Yes,
treating as it's
Yes.
imaging.
Is MR also tomotherapy?
no, tomotherapy is the manufacturer's name for that.
Like,
So it won't be tomotherapy is a treatment machine like a Varian Linac.
Mhm.
So.
That's what Bay Meadows is getting rid of.
The one that Bay Meadows is getting rid of, yes. Or has gotten rid of.
Yeah.
So yeah, there was only one in the city and they've got rid of it. Because, well, I'm not sure the politics of it, but they couldn't do electrons. If they had a patient with electrons, they had to send them somewhere else.
It's because Genesis Care wants all of their sites to have elective. So they're slowly transferring
Yeah.
everything to that.
Mm-hmm, yeah. So that's what a tomo is. Now there is, if you say to an X-ray tech, what's tomotherapy? They would give you a completely different answer. That's the type of machine that they used to use before CT came in, and it gave you slices of the patient, and it sort of did this. And it gave you slices of the patient, 3D slices.
Yeah, I've just had 2 tomo mammograms, so
Mammograms are
it goes
different
around.
from tomos, usually.
but
But they're doing
they
mammos and
have
tomos now.
Oh, they're doing mammals with tomos now?
yeah,
Okay. So that's completely different, obviously.
yeah.
So if you asked an X-ray tech what a tomo machine was, or a tomotherapy machine was, then you would get a completely different answer. Okay. Can somebody tell me what EPID stands for? EPID.
Jesus.
I'm sorry, I tried to hold them in.
Something image device.
Imaging device, yeah.
Isn't that another name for the MV imager?
Is it? So what do you call the MV imager correctly? Portal imaging device. So what's the E?
External?
No. What is the,
I have the hiccup.
what did we used to use before we did images? What are these things in the brown?
Electronic.
Electronic. Those things in the envelopes are called portal films, right? So you've just given an electronic portal imaging device. So the electronic version of those things are electronic images, portal images, as opposed to portal films. You'll notice that a lot of people use it interchange between portal images and portal films. Depends on how long they've been in the field. Some people will say film, some people will say images. It's the same thing. Everybody uses images now. Most of the time. So portal and EPID is electronic portal imaging device. So what is that? What do you use this for? It's in the name. You're doing portal images, yeah. So that's your MV imager. What are fiducial markers? What are fiducial markers?
They're internal and external markers. Like BBs.
Okay. Give me an example of an external fiducial marker.
BBs.
BBs, okay, BBs. Give me an example of an internal marker.
Surgical clips.
Surgical clips or prostate markers. Anything that somebody inserts into the patient. So has anybody been in SIM yet, in CT yet, to have a look-see? Has anybody seen the use of something called a vaginal marker?
Yeah,
Yeah?
yeah, I saw it on a.
That's also a fiducial. So a vaginal marker is usually a piece of rubber, plastic, and it has little babies on it, inside of it. And they basically place it in the vagina so that if you're doing a pelvic area, endometrium, uterus, cervix, something like that, you can see where the vagina is. Same with the rectal marker. You can see where the rectal marker is, or the rectum is. Fiducial markers can also be what they call a natural anatomic structure.
Calcifications,
Pardon?
like calcifications.
Calcifications, yes, but something like a, for example, the symphysis pubis is always recognizable, right? Everybody when you see the symphysis pubis, you know what it is. So something like that can also be counted a fiducial marker. Or if the patient has an extra little horn on one of his lumbar vertebra, an extra piece of bone or something, you can use that as a fiducial. Something recognizable as an anatomical structure.
It can be something that like they already have implanted that we didn't implant that we used.
Yeah, it's something like an abnormality of the bone, for example.
Like this one lady has like this T-looking thing that holds her bladder in place, because her bladder falls.
Yeah,
So
you
we
can
use
do that.
like that's
Yeah,
what they-
yeah, you could use
But
that.
we didn't do that.
No.
It was already there.
No, that's something obviously some surgeon has put it.
Yeah.
But it's there, and she's gonna have it for at least as long as you're treating it. You don't want something that is put in there and then is gonna get taken out. Yeah, because you need it. You managing okay with your mask?
Yeah.
Okay. You'll notice that you've got marks down.
Yeah, I'm sure. I can feel it, but I was just feeling something else.
Okay.
I might have to go take a walk in a minute.
Okay, so we're almost there. Oh yeah, it was 10. So stereotactic body radiotherapy. We've already done this. Annabelle, we better. Okay, yeah.
Is it a bonus question?
Stereotactic radiosurgery. Which machine was used historically? Which machine was used to treat it first? Stereotactic radiosurgery.
Ow, oh my fuck. My ankle's weird.
Gamma knife. Yeah. Gamma knife. If you're using a CBCT to position a patient with prostate cancer. What are we normally going to match?
Oh, prostate seeds,
Sorry?
little prostate seeds, like the little fiducials or whatever.
The seeds, okay.
No.
Not everybody gets them, so I'll accept that, but is it, let's put it this way, is it going to be a soft tissue match or a bony match?
Soft
Soft
tissue.
tissue.
Soft tissue. Anybody otherwise? Some places do both, but normally it's a soft tissue match. Why is it a soft tissue match?
Because what we're treating is soft.
Yeah, it's a prostate. Now, some people, I'm told, and I've experienced it myself, physicians will insist that you don't worry about the prostate, you do a bony anatomy match. Why is that,
Because your soft
what's
tissue
it
can
wrong?
move.
Yeah,
but why is that ill-advised?
because it moves.
What moves?
Your
Yeah,
soft
prostate.
tissue.
The prostate moves, yeah. So if you have a physician that says, I want a bony anatomy match, and yeah, I don't want to do that, but
And you can't even go off the bladder either. I've
Oh,
learned
hell no.
this.
yes,
Because I'll be trying to line it up and they'll be like, don't focus so much on the bladder. That don't even matter because this guy's bladder ain't even full like it's supposed
No.
to be.
no, you have to, go with the prostate.
Yeah.
And that's something that, why we stopped doing, ultrasound. Nobody here has ever seen an ultrasound done as IGRT, right? That's because nobody uses it anymore, because simply it's easier to do a cone beam CT. But what we used to do with ultrasound was that you have to have the bladder full, and the bigger the patient, the fuller the bladder had to be. Because what you were looking for was the bladder prostate interface. So the prostate sits here, the bladder sits opposite, right? Or on top of it. Then when it's full, it goes up. So what you're looking for is the junction between the bladder and the prostate. You can actually see it, but you have to have a full bladder. And if anybody has ever had an abdominal ultrasound with a full bladder, they know how difficult it can be. And if you're a big person, especially some of these guys that are really, their belly's really big, and you're pushing on them because there has to have a full, and of course ultrasound you have to push, and the bigger the patient, the fuller the bladder has to be in order to get a decent image. It can be rather difficult, shall we say, and excessively wet because they tend to do.
Hope you have a chuck under there.
Yeah. So that's basically why the main reason was that CBCT is much easier and much less time consuming. Okay. So what is hyperbaric oxygen?
It's where you change the air pressure to treat cancer.
Okay.
Forcing oxygen to the cells via hypobaric chamber.
Hyperbaric. So, given that sea level is 1 atmosphere, are you using a higher atmospheric level or a lower atmospheric level?
Hi.
Hi.
Higher.
Yeah.
And what does it do, or what did they think it would do? What was the reason they decided to do this?
Make it more radio sensitive.
Make it more radio sensitive, and it worked with some areas, but it didn't work for others. Yeah. Okay, so IORT, which is,
Interoperative.
yeah, so who has to be present when we're treating
Surgeon.
IORT? Pardon?
Surgeon.
Surgeon. That it?
RT. Radiation therapist.
Radiation therapist? Not really. What else?
The oncologist.
Anesthesiologist.
Which oncologist?
Radiation.
Radiation oncologist. Sorry, I missed that.
Anesthesiologist.
The anesthesiologist would be there if the surgeon's there, yeah, okay. So the surgeon, a radiation oncologist, who else?
Patient.
Thank God.
Okay.
I need one, come on.
And there's a surgical nurse and a radiation oncologist.
Radiation oncologist, the surgeon, physicist, because somebody has to do a plan, right? And then, believe you me, the doctors don't want to do that, whether they're good at it or not, or whether they think they're good at it or not. Same as if we were, this is totally outside of what we're doing here. When you get called in the middle of the weekend to do an emergency treatment, physician sometimes comes in with you. Why? Because they think they are needed. Are they needed? But they like to be helpful. And if you have physicians trying to help you move a patient, that's always fun, because they have no idea what you're supposed to be doing. Okay, so now we get to the short answer ones. So I'm going to give you the questions and you can think about them, but we can discuss what you're going to put down. What is a boost when applied to radiation therapy? Tell me what a boost is. What is a boost?
An additional dose to a more restricted, smaller area.
Restricted and small is the same thing. Okay. Okay, so a boost is, can somebody else give me another answer to that? You're right. So a boost is what? It's not as much as I've hoped for, that answer. Okay. When is a boost, okay, let's start with this one. When is a boost given?
After.
At the end of what?
Or so.
Oh yeah.
Okay. Is it usually the same size or smaller?
Smaller.
Smaller. Is it normally it is given at the end of the prescribed treatment? Now, there are times when they're done concurrently, not very often, however. So they're usually done at the end of the treatment. Why? Why is a boost given? because they want to give more treatment to a specified smaller area for whatever reason. What's the normal reason for giving a boost? Pardon?
Reduce recurrence.
Reduce recurrence, okay, or reduce the
Chance.
probability of recurrence. What area is is mostly done as a boost? A scar. Yeah. Okay. What is brachytherapy?
Internal radiation.
Need a little more information on that one.
Place radioactive seeds into an area of a body.
Into the area of the body. A little more than that. What are you trying to do with these radioactive bodies? It's not just seeds, it's needles or tubes or threads. So
Devices.
what are you trying to do? Where is it going?
As
Middle
close.
of the target, or trying to get as close to the middle of the
Middle of the target.
target,
And what is the target?
Tumor.
the tumor.
The tumor, yeah. So brachytherapy is treating with radioactive isotopes, sealed radioactive isotopes into or close to the tumor. Okay? And you can add more if you want. What is an immobilization device?
Customized to patients.
Say again, wait to the
Device customized to individual patients to make them as reproducibly positioned as possible.
Okay. In order to,
Give the same treatment every time.
sorry,
In order to get the same treatment every time.
in order for the patient to be in the same position every time. Okay. Give me some examples of an immobilization device.
Mask.
Mask. And backlock. Yep. Okay. What are metastases? What is metastasis?
Cancer that spread.
No. Cancer that spread, if you say cancer that spread, that just means cancer is spread. It is not counted metastasis. Because cancer that spread, it could be just it gets larger.
Spread
That-
to
Cancer-
an area of the body.
Systemic spread.
Okay,
Traveled.
yeah, okay. So metastasis is cancer which is spread to another part of the body. So you have cancer of the breast invading the spine, or cancer of the breast invading the lung. It's still a breast cancer, but it's in the lung. It's still a breast cancer, but it's in the spine. So it's not spinal cancer, it's not lung cancer. It's breast cancer that's spread. Okay. And to add to that point, what is palliation?
You're not treating to cure, you're treating to lessen the symptoms.
Okay.
Sort of.
Anyone get anything to add to that? About palliation?
You could treat like I'm trying to think of the verbiage that I want to use.
To improve your quality of life.
Yeah.
Or
Use the quality of life.
to control the tumor growth too, so that it doesn't get like bigger.
To relieve symptoms. Basically, palliation or palliative treatment is to give patients relief of symptoms and improve their quality of life. So that's basically what palliation is. So what kind of symptoms can you improve?
Pain.
Pain?
That's the main one.
Huh?
That's the main one.
Yeah, not necessarily the main one, but yeah, it's a main one, yeah.
Headaches.
What else? Huh?
Headaches.
Well, that's still
That
good,
is
yeah.
me.
Nausea.
Nausea probably wouldn't be counted palliation.
Swelling. I don't know.
Swelling, yeah. Pain, swelling, breathing, or lack of such. Hemorrhage, and I'm not talking bleeding, I'm talking hemorrhage. Those are the main ones that you would cite if somebody asked you what symptoms you were wanting to help. Okay, tell me what you know about CT simulation. What is CT sim? Anybody? What's CT sim? What do you do? Why are you bothering putting them into the CT?
To figure out how you're going to position the patient and take images so that a plan of like dose and all that stuff, with the symmetry and physics and all that fancy stuff can be created.
Okay. I trust you'll write something a little more copacetic than that. But yes, okay. So anybody else want to tell me?
Words are hard. I'm totally with her. Words are hard.
Yeah, okay. So basically CT sim is, CT is used to give the dosimetry and physics images in order to plan the individual treatment that the patient requires. or words to that effect. So everybody has seen a radiation therapy plan by now. What does it consist of? The plan that you get from the cemetery. What's there? What is it? What is it? What's in the plan?
Plant treatment volume.
Treatment volume.
Organs of risk, dose,
Mm-hmm.
angles.
Beam angles. Okay. What else?
I know it tells you like the shifts you need to make on the
Okay.
machine.
So that's patient positioning, I guess you would say that, right?
I'm trying to think what I use it for, because I use it for different things than they do, I guess. That's my job.
So a treatment plan is basically given to you by the dosimetrist, which has been approved by the physician, and it gives you all of the parameters needed in order to treat the patient. It has to be signed and dated by the dosimetrist, the physicist, and the physician before treatment can be given. Does that make sense? And you can specify what's in there if you wish. The treatment volume, the angles, the doses, the shifts. Okay, here's an easy one. Define the eye as a center. You'd all know it by now. Okay, somebody gonna tell me? The eye as a center is what?
The point in space where the gantry, couch, and collimator meet.
I lost you after call me.
Meet.
A point in space in which the gantry, collimator, and couch rotate.
Yeah, around which, yeah. So the eye as a center is a point in space around which the gantry, collimator, and bed or couch rotate. So what's a DRR? And how do we use them?
Your digitally reconstructed radiograph
Mm-hmm.
comes from two orthogonal pairs images.
No, not necessarily. That's what is normally given us. But what do we use the DRRs for then? DRR, you're correct, is a digitally reproduced or reconstructed photograph. And you're correct again that it's usually a pair of orthogonal films or orthogonal images. What do we use it for? Or what do we use them for? What do you use DRRs for?
Shows us where the MLCs are going to be around.
Okay, is that all? When you do a portal image on your 5th fraction day, you use a DRR to do what? You have your portal image here, and your DRR image up here. What do you do with them? You can either superimpose them and make sure they're good, or you can just look at one and look at the other and look at one and look at the other and say, okay, they're fine. And send them off to get seen. So they are used as reference material to check your portal images or the position of your patient. Can you do portal images more frequently than
Yes.
every 5 fractions?
Yes.
When would you do them more frequently?
When your cone beam's not working.
Pardon?
When your cone beam's not working.
When your cone beam's not working, okay. Yeah, anytime that you have a problem positioning. If, for example, the patient has lost a lot of weight, or they've lost their marks, or something like that, or they're just not setting up correctly, then you can do a portal image. Okay. Couch indexing. What's couch indexing? I'm sure you've all seen it done. What do we mean by couch indexing? No? Nobody knows what couch indexing is? If you're placing a patient in a mask and you're attaching it to the bed.
Oh, you're talking about the numbers,
Yeah.
like the Q-fix?
Yeah, you can do that. Yeah. So how do you index the couch? Tell me about Q-fix.
You put it on 5 or 6 for
Pardon?
you put it on 5 or 6 for heads.
Okay.
So essentially the patient is indexed in CT and that has to match what is on your couch.
Yeah.
And
So how do you index them in CT? Is there anything you use to index your patient? To position your patient in a particular area of the bed?
what are those things called, the pegs?
Bar, like the
Yeah. It's the,
Called index bars?
yeah.
Yes, so the index bar is a.
Oh, those
is a
are those black
thing.
things.
Yeah, the little
Gotcha.
black thing that goes onto the bed, right? And the mask or the head base will fit in that, on that bar. And then the mask goes on top of that. Or the vac lock has a bar at the back with 2 holes in, and it goes into the,
So we don't
Little
use
pegs.
those black bars for the Q-fix. You just
no, you don't,
put the
you have
Q-fix
other
on.
things that you use. But that is what the indexing is, Q-fix. It's still an indexing
Oh, it's just like a
system.
device.
Yeah.
Okay, so like the indexing bars are one device and the Q-fix is
Yeah,
one
It's
device.
another, that's, basically think about what you use to make sure that your patient is in the same position on the bed every day.
Would the vac lock be a device?
The vac lock.
Or is that not
the
because
vac
you use
lock
the
is
indexing
actually
bars?
attached to the index
Bars.
bar.
And the breastboard as well,
The
right?
breastboard can be fit onto the index bar as well, yes. And sometimes in 2 places. The back lock can be fitted into 2 places as well. So if you have 2, that one down here doesn't have any index bars, but the ones upstairs has either 1 or 2 bars with holes in. And you can put one on one index bar and one on the other. And therefore your back lock will not move. If you have to move some, you have to move a patient.
Is it considered indexing when you change the angle on those breastboards, or you change the
No,
butt plate? That's
no,
not considered
no,
indexing.
it's
It's
just-
only the part
it's-
that attaches to the
the
couch.
bed, because that's what the couch indexing is. So, and the other reason is if you start on the CT with a certain, the index bar is on number 12, then the bed on the machine has to be exactly the same as the bed on the CT, which they usually are. You're in trouble if they're not. Then you put, that's part of your setup instructions from CT. Mask index bar at number 12. So you put your index bar on 12 and you're sure that the patient isn't exactly the same place every day.
So the new machine.
Okay. I've got 5 minutes. Has everybody signed up for next
Oh shit.
semester's classes?
I will though.
I would suggest you do it.
Is it just dosimetry and clinical?
The symmetry and clinical, yeah. You'll notice that there's a lab for the symmetry. Have you noticed that?
So is it
Ignore
dosimetry
the
and lab?
Just-
Oh, okay.
Just sign up for the class, and it should say dosimetry and treatment planning, or treatment planning and dosimetry. I'm not sure which way to do it. And the lab will take care of itself. So you're only signing up for 2 classes, dosimetry and clinical.